Good morning, everyone, and welcome to another edition of Cardiac Surgery Rounds. Well, it's actually NB Heart Centre CV weekly rounds. And today's topic is going to be presented by myself. So it's a little self-introduction. Many of you obviously know me well. For those of you who don't, I have been a member of the New Brunswick Heart Centre since January of 2009, and I joined the program at that time after having done a cardiac surgery residency at Dalhousie University, and then did a minimally invasive fellowship and a robotic fellowship with Dr. Chitwood in North Carolina in between 2007 and 2009, and after that joined the program here with Dr. Mark Pelche, Dr. Rand Forgy, and Dr. Craig Brown. So the minimally invasive program is something that I kind of helped to introduce to New Brunswick at that time. And I thought I'd kind of go over a little bit of the evolution of our program since then and provide a little bit of insight into, some of the, some of the learning curves that we've had to engage over the years, and some of the successes that we've had as well, and where it is that we hope to get to. So traditionally, the midline sternotomy has been our approach for most open heart cardiac surgery. It's really, to be honest, still the gold standard as far as access is concerned to cardiac surgery cases. It gives us the best access to almost all cardiac structures, with the exception of the distal aortic arch and the descending thoracic aorta. Unfortunately, though, as many of you know, the sternotomy is associated with a significant recovery time. We typically tell our patients that after surgery, there will be 4 to 6 weeks of no heavy lifting or driving, 3 months really until all restrictions are lifted, but most importantly, 12 months really until the bone is truly healed. It doesn't mean that they can't go out and do what it is that they want to do, but it is 12 months till you have proper union of the sternum. And as we all know, the sternotomy is prone to complications, whether it be bleeding, dehiscence, superficial or deep infection, or chronic pain, especially in at-risk patients. So what is minimally invasive surgery? Well, by definition, minimally invasive surgery is any surgical procedure that's performed through a smaller incision. There's not a particular location for this kind of surgery. It's often referred to as keyhole surgery or porthole surgery, but it's really any surgical procedure performed through a smaller incision. The principles behind minimally invasive surgery is that it is less invasive, less disfiguring, and obviously better from a cosmetic perspective. And hopefully, ultimately, because it's less invasive and less disfiguring, there's less recovery. And the most common approaches are usually the mini thoracotomy approach for cardiac surgery, whether it be right-sided or left-sided, or a hemi or partial sternotomy. So this is Dr. Randy Chitwood. He started the cardiac program in Greenville, North Carolina, and founded what you see to the right, which is the East Carolina Heart Institute, from the ground up. And this is truly one of the pioneers worldwide for minimally invasive surgery, and more specifically for robotic cardiac surgery. He actually conducted the first FDA-approved clinical trials for robotic cardiac surgery as it related to the mitral valve. So we would have people coming from around the world who would visit our center regularly to get trained in robotic surgery. And they were learning from people like me, which would indicate why robotic surgery has not taken off. So conceptually, this is theoretically where we kind of have, if we were doing a camera port, it would be placed in the second intercostal space. A cross clamp typically goes through the third intercostal space. The 5 centimeter or so incision is typically in the fourth intercostal space. And if we have an atrial roof retractor, we pass that also through the fourth intercostal space, but more in the parasternal position. The result is something that looks like this. And this wouldn't be doable or feasible if we weren't able to cannulate the patient and put them on cardiopulmonary bypass using alternate techniques. So typical techniques of putting them on bypass include cannulation through the groin. Usually the femoral artery and femoral venous cannulas are put through the groin. And then we also put a separate right neckline up in the right internal jugular. All of this is thanks to the abilities of our anesthesiologists, who are able to do this fairly easily in conjunction with the help from our nurses and anesthesia technologists. So as you can see here, this is what it looks like. So instead of having everything transpire through a sternotomy, what you have is you have a small right anterolateral thoracotomy incision in this particular instance, and then you have a neckline and you have the groin cannulation sites. Now, of course, in North Carolina, this is Dr. Chitwood. This is my fellow at the time. This is my colleague she is now currently a cardiac staff in Newmarket in Ontario, Dr. Carolyn Tang, and this is Marvin, who just friended me on Facebook, which is exciting. And this is the robot that we were using. So we don't use the robot here, but we were able to accomplish everything else without the robot using sort of a long shafted instrument strategy and obviously small incisions. So our result looks very much like this. This is once again the right anterolateral mini thoracotomy. In this case, right underneath the breast. Once we do kind of retract considerably to be able to get into the fourth intercostal space. These are a couple of chest tubes that are put in the right pleural space after surgery. And these are the little holes that we use to be able to retract the pericardium through the chest wall to be able to put the chest tube, the cross clamp through the chest wall. So all of this really gives us very good access actually to the, through a lot of structures in the heart. In this particular instance, it was a mitral valve, but we have great access otherwise to other structures, which I will discuss further in the conversation. So these were a few papers that I put together while I was in North Carolina, systematic reviews and reviews of our particular experience. And what we typically found, and obviously these are large volume centers, what I typically found is that minimally invasive surgery was associated with improved cosmesis, that's for sure, less recovery time. And this I can attest to when we did a town hall meeting with patients of ours that had undergone minimally invasive surgery. What was most astounding is that while sternotomy patients typically tend to say that it takes them about 2.5 months before they feel good or normal again, a lot of the minimally invasive patients, it takes them about a month. And what we've often been doing now is we've been saying after a month, you really have no restrictions. You can do whatever it is that you want. So whether it be psychological, clinical, or otherwise, the recovery time is indeed less. As a result, they have faster return to daily activities and the workforce. There's less blood loss and transfusion in these cases, typically. And then last but not least, the results are equivalent, if not better, in certain instances. But what are some of the disadvantages? Well, there is a steep learning curve. Operative times are often prolonged at the onset, and this is somewhat challenging. This can be mitigated in a high volume center where you're doing a lot of cases and you're able to get past this learning curve in a shorter period of time. But when you're a smaller volume center such as ours, it can be a deterrent because it can be somewhat disheartening when the same case that would typically take 4 or 5 hours is now taking the entire day. So what is the history of our program? Well, the history of our program is this. Back in 2010, we did our first minimally invasive case. So 2010 was a big year. We did our first TAVI, we did our first minimally invasive surgery. As a group, we went down to Philadelphia under the sponsorship of Edwards, and we observed a couple of cases. And then between what we learned there and the techniques that I had learned during my fellowship, a core group of us got together, and there was an anesthesiologist, Dr. Jennifer Cloutier, myself, Mark Pelche was the second surgeon involved in the program at the time. We had a couple of our nurses that went down with us, Jackie Jones, for instance. We had a couple of our perfusionists. Actually, Chris Fowler went down with us. And as a group, we kind of formed a core entity. But then eventually we realized in order to make this practical, we needed to train everyone so that we could all do this and do it in a way that would allow, the surgery to happen irrespective of who was in the room. But of course, as I said, there were growing pains. I mean, this was technically challenging. It was resource intensive, and it was time intensive as well. But, we persevered. And what you can see here is a number of cases. In purple is the ones that were done minimally invasively, and then in gray are the ones that were done using a conventional strategy through a median sternotomy. These were isolated mitral valve replacements and or repairs. And this is work that was done actually by one of our nurses in the OR, Monica Fowler. And I'm taking kind of this from her presentation that she made this past year in New York at the International Society of Minimally Invasive Surgery meeting. And what we see here is that, through our perseverance, our numbers of minimally invasive cases are going up relative to those that are being done conventionally through a midline sternotomy. And what's really nice to see is that there's an improved efficiency. These are cardiopulmonary bypass times on the left-hand side in gray, and on right in purple are the total operative times. And what you see here is that the minimally invasive cases have definitely reduced in terms of the amount of time spent on cardiopulmonary bypass and the amount of time spent as a whole in the operating room from the time of entry to the time of departure. As far as the conventional cases are concerned, well, those are also reducing in time, but not to the same extent. And to some extent, we're starting to see a plateau or a flattening of the conventional mitral cases. So all of this speaks to something. And what is that? Well, before we get into that, what about some of the outcomes? Well, as far as the outcomes are concerned, once again, this is all work that Monica did. We see that our mortality is very acceptable, if not better, in the minimally invasive cases. Yes, this was unadjusted and there's a bit of a selection bias. And the selection bias is that initially we were taking lower risk patients, people who were younger, who were not obese, who had no, cardiomyopathies, reduced ejection fraction, et cetera. So as a result, we were getting excellent results. Mortality was low, renal failure rates were low, atrial fibrillation rates were lower, and median length of stay was lower as well. Once again, all unadjusted. And as I said, the keys to success for this were to some extent patient selection, obviously. Another thing that was really important for our group was to have the consistent approach. A lot of what we are doing today is exactly how we did it when we first started. So being able to have the same process in place allows us to expand the process out so that we can include more nurses, including those who are new or just training, all of the perfusionists, all of the anesthesiologists, and included in that is also more of the surgeons. And then team engagement has been excellent. This really has been very much a group effort. Great ideas have come from all aspects of the operating room, and it's really not just a surgeon-driven model. This is truly a group-driven model, and I think that has been a huge part to the success that we've had. But there are a couple of things that we've done along the way that have also considerably changed the landscape of cardiac surgery, and more specifically, minimally invasive cardiac surgery. So first of all, the adoption of single dose as opposed to multi-dose cardioplegia. So for those of you who don't know, what is cardioplegia? Traditionally, cardioplegia is a cold solution that's high in potassium that's administered to the heart after we clamp the aorta, and it arrests the heart in diastole. It allows for us to operate in a motionless environment and in a bloodless environment. The problem with traditional cardioplegia, though, is that it runs out in the sense that you give it, and then in 10 to 20 minutes or so, the heart starts to beat again. So you need to redose it repeatedly in order to maintain that motionless, bloodless environment. Well, what about single-dose cardioplegia? Well, some of you may be familiar with the terms Del Nido or custodial, Brett Schneider. What we use here is the KBC formulation, which is a formulation that was started by a group in Atlanta. And this KBC formulation is a combination of a variety of things. So there's obviously potassium, and that's really the arrest principle. Then there's mannitol, magnesium sulfate, lidocaine. And some of these act as buffers, they act as membrane stabilizers. The whole point here is that what we can do now with this is that we can administer cardioplegia using this particular device, which is the Quest system, all blood, no crystalloid, which allows us to minimize systemic hemodilution, minimize myocardial edema, and it really gives us the ability to precisely control what we're giving at what point in time during the case in terms of composition, flow, pressure, and temperature. The beauty of single-dose cardioplegia is that initial dose, instead of giving me 10 to 20 minutes, imagine through that small hole, I now have 60 minutes of uninterrupted operating time. The reduced rates of VFib post-removal of the aortic cross-clamp are excellent. That definitely helps. I've noticed a big difference. Yes, some would argue that for the most part, we initially see no activity for a little while and that we have to pace, but that beats having to shock the heart repeatedly to try to reestablish some kind of a normal rhythm. What I found, though, is from the time I remove my cross-clamp to when I wean from cardiopulmonary bypass, that time period has shortened considerably with single-dose cardioplegia as opposed to the traditional multi-dose system. The next is the Coronat device. The Coronat device is a suture tying device, and this device has really been a true game changer. A lot of the reps will come to you and offer you game-changing valves, game-changing grafts, game-changing this, that, and the other, but very few things have been truly game-changing the way the Coronat device has been. So what is the Coronat device? The Coronat device is literally this structure right here, and what it has within it is a rivet. The little rivet allows you to kind of basically tie a knot without having to put your hands down into the hole or use what's called a knot pusher deep down into the hole. It basically takes the suture up, passes it through this rivet. The rivet then goes down as you push down on the particular device, and then it deploys the rivet, thus tying the knot for you, tying in quotation marks, but it is a secure rivet that will not loosen up, you know, in a way that a knot could potentially loosen up if you haven't done it properly. And then what's excellent about this is that the device also cuts at the same time. The time saved is incredible. The simplicity that has been afforded by this particular technique is incredible. When you think about the ability to now tie knots through a small incision into deep spaces, you can do it all with fairly minimal difficulty. Once upon a time with a knot pusher, the assistant was key in terms of being able to hold onto your other stitch while you pass this knot pusher down. And what was important for this particular technique is that there had to be exactly the right amount of tension to offer traction and counter traction. Needless to say, there were plenty of snafus during this particular part of the case. There was air knots, meaning knots that didn't lay down perfectly, knots that were loose, you know, things that just did not go right. Once we got this device, it changed everything. So between single dose cardioplegia and the Coronat device, we've made huge gains forward in terms of what it is that we're able to do. So because of, you know, the improved efficiencies and the improved techniques that we've had, you know, we're able to push boundaries. So where to next? Well, first of all, there's no doubt that our patient selection is now expanded. Once upon a time when we were cherry picking lower risk, younger patients who were anatomically easier to look after, now we are into higher risk patients, those who are elderly, obese, people with low ejection fraction, even those with pulmonary hypertension. No longer am I sort of restricting myself to people whose pulmonary pressures are relatively normal or only just slightly elevated. Now I will take somebody on with a pulmonary arterial systolic pressure of 70 or 80, provided, once again, that their right ventricle is working well and they don't have other comorbidities that could potentially make them a non-operative candidate or at least a non-MIS candidate. Through a right posterior lateral mini thoracotomy, and you've seen those pictures earlier in this presentation, we can now easily or comfortably do complex and simple mitral valve repairs, mitral valve replacements. We can do tricuspid valve repairs and replacements. We can do combined tricuspid and mitral valve cases because, once again, the right atrium and the left atrium sit really one on top of the other. We've been able to do ASD repairs and PFO closures. And then last but not least, we've been able to resect myxomas. Now, we've also done maze procedures, usually in concomitance with another procedure, but we have done those as well through a right posterior lateral mini thoracotomy. What about the mini AVR? Well, we're trying to grow this program and we're doing it slowly. Some of you may have seen cases where an AVR was done through a hemisternotomy or a partial sternotomy. This we've been doing for quite a while, and we have a few surgeons right now who are doing these quite comfortably. I've been trying to grow this particular program. It seems to be a natural departure from the right mini thoracotomy mitrals, and trying to do a AVR through a right anterior thoracotomy. It seems to be the next logical step. Obviously, it's not that straightforward, otherwise we would have done a ton of these by now. First of all, number one is that you need to do CT scans in these patients to make sure that their anatomy lines up so that when you do open the right chest through the small right anterior thoracotomy, usually in the second or third interspace, you need to have good visualization of the aortic valve. The other thing also is that, to some extent, this particular technique hinges on the ability to use a sutureless valve. This is a valve that instead of tying down with sutures, you actually pass through and then deploy it much like you would deploy a TAVI. So it's a self-expanding valve. There is a learning curve to this, which I admit at times I feel like I'm still on, and other times it goes great. And I think this is one of those things where if there are people watching from the OR right now, I'm sure there's some eyes rolling. But it is a great technology when it works, and when it doesn't, it can be frustrating. What about minimally invasive CABG? Well, interestingly, we went down to Ottawa in 2013, so about 2.5 years or so after we did our first case, and we learned the idea of doing a single vessel CABG through a small thoracotomy. Now, the person who we learned from, Dr. Mark Ruel, he actually has done multi-vessel small thoracotomy CABGs. We kind of just focused on single vessel, and to this point right now, we're limiting it to Lima to LAD. The hope is that one day we will expand it out to more, but for now, left anterior mini thoracotomy incision. This was actually our first patient. This is the incision, usually done off pump. So who should be considered for minimally invasive surgery? Well, first of all, anybody with isolated valve disease, people with combined mitral and tricuspid valve disease, people with single vessel LAD disease, simple congenital defects such as an ASD or a PFO, and a simple atrial mass or tumor. And what I didn't put here was atrial fibrillation, isolated or in combination. But I think that's something that we did a lot of in North Carolina. And if we were to grow that program, that would be something we would do in conjunction with the EP physicians. If you're asking how can I refer a patient, well, I think the automatic process is to send a referral either to myself or to Dr. Jean-François Legaré. Both of us are really the ones who are doing the most of the majority of the MIS cases here. And request that the patient be considered for MIS. I think that's important because oftentimes when a patient gets sent down for a cath, if it's not indicated specifically that you want an MIS consideration, then it doesn't automatically get shuttled into an MIS category. So I think it's important that, if as a referring physician you have that in mind, then you should put it down. Are there any tests that are needed? It's the usual stuff. I mean, at the end of the day, we need a good echo to indicate what the disease process is. Do we need a TE? Not necessarily. A cardiac cath, obviously, to rule out coronary disease. If there's significant coronary disease, then doing them minimally invasively is not an option. I used to CT scan every patient, but I've kind of stepped away from that. I will CT scan those patients who I'm worried about in terms of their thoracic anatomy, for instance, if they have a severe pectus or issues with vascular access. And then pulmonary function tests in anybody with lung disease. Obviously, because we tend to use a lot of single lung ventilation during these cases, it's important to know what lung function is. Future directions. This is Halifax. This is their current robotic hybrid suite. And as you can see here, they've got a robot. They don't even actually have a minimally invasive cardiac program. We're actually the only program now in Atlantic Canada that does this, now that Dr. Corey Adams has left Newfoundland. So we are the only true minimally invasive program across Atlantic Canada. And I would love to see us eventually move to a hybrid room suite where we have a hybrid room with all of the imaging technologies available to us and the robot to be able to provide us with improved dexterity, improved visualization, and increased capacity to do more things that we otherwise are limited by using our current technologies. So in conclusion, minimally invasive cardiac surgery at the Heart Centre has evolved considerably over the past 10 years, thanks to really the incredible partnership that we've had between surgeons, nurses, anesthesiologists, assistants. I think it's been really key. And we are, as I said, really the only center now in Atlantic Canada that provides these services. And I think we need to continue to push the boundaries in an effort to offer more patients an alternative minimally invasive approach. I will say this as a bit of an editorial remark. I think there's probably some resistance at the level of administration and maybe even government because of the costs associated with this. But nevertheless, I think it's important for us to really push the envelope as best we can and to be truly the leading heart center, not only locally, but regionally and maybe even nationally. Thank you.
That's a great talk, Ansar. Thanks for the history, and it's pretty impressive to see the growth of the program over the last 10 years. With the last statement you made that we are now the only MIS program in Atlantic Canada, have you seen any referrals from some of these other centers, so from Newfoundland or from Nova Scotia, specifically to be considered for MIS surgery now that that's the case?
Yeah, so actually I've currently got one patient that has been sent to me from Nova Scotia. Actually, it was a self-referral, somebody who saw online that it could be done minimally invasively and wanted to seek us out. And his reasons were because he didn't want a sternotomy, has a history of PTSD from his time in the Army, and is scared of the potential ramifications of being limited by a sternotomy. So, we have given talks in the past and we've encouraged them to send us patients if they're not doing them this way. And I think we'll just have to continue to do that. Obviously, we have our own waitlist issues, so it's not like we're open for all comers, but having said that, we will do the best we can to accommodate people from elsewhere.
If anyone else has questions, please feel free to put them in the chat, or just shout them out. I'll maybe ask one more while we're waiting. Are there, is there, other than a robotic program, is there kind of a pathology or next frontier in terms of a patient presentation or pathology that you think you would like to tackle next, or is it just a matter of, growing the current program, the patients we're currently seeing, and improving, efficiency in those patients that you're treating already?
I think the frontiers that we really need to tackle, and we need to tackle consistently, is the aortic valve program. I think we have such a great TAVI program. I think in order to have an ideal partnership with that, we need to have a really solid, minimally invasive aortic valve program to go with that. And then I think the other thing also is that we need to be able to consistently feel good about doing at least a single vessel CABG through a small thoracotomy. And then I'd love to see us tackle maybe even 2 vessel CABGs. I can't tell you how many times patients ask me if there is a minimally invasive approach that's available. And, oftentimes I will say, well, to be honest, if you were at a different center, potentially, but there's not many centers that do offer this. And, in our hands, this is the best option for you. I think we really need to kind of step out of, like, I personally want to step out of my comfort zone and kind of push the agenda. I think it's nice when you have 2 surgeons who are of that mindset. And we really have built a foundation. We really have built a foundation with our minimally invasive mitral program, such that a lot of the techniques really overlap. So it's not like we have to go out and get new instrumentation suddenly. It's not like we have to get new skill sets, and they're minor additions to a platform that's already very solid.
Any other questions from the group and audience?
That's great.
All right, Ansar, 1 minute to spare.
Yeah,
Thank you very
thank
much
you.
for the talk, and have a great day.
And then next week, next week we have Dr. Yaroslav Hubacek, who will be talking about alternative diagnostic modalities in the cath lab. So see you then.
Thank you.
Thanks, Chris.